Okay, Assalamu alaikum. Let's start. I'm Dr. Karim Minhas and a member of PNMDP. I welcome you all to today's session on COVID-19. And as you all know, PNMDP is working to enhance your knowledge and prepare all of you guys for the exam, for all the exams that you are preparing for. These are our Facebook page and Gmail ID and the website link. And it's founded by Dr. Ayaz Ahmed, and board members included Dr. Adil Khalid and Dr. Ishad Bajir. And these are all the members. This is our March session. We are almost at the end of the first round, and this is the second round that you will be following. You guys can also follow us on YouTube channel, and you can see the upload of the common videos there. All of that you're requesting, you can follow the channel and you can have them there easily. And it is also our special request for our website sections. Any one of you can contribute for the short long case section. There's this image video section. You can send image of your patient with clinical signs with 4-sentence description of either disease treatment or any recent advances. And the interesting case competition, common case with atypical presentation, this is also in line. You can contribute, and you can also contribute to the PNMDP blog section. Any clinical topic, theory topic, clinical leadership skills like ABG interpretation, approach to short stature, anything that you find interesting, you can be a part, and you can also contribute to the website. So for details, you can contact pnmdpp@gmail.com. So you can also, all of those who have who are training at the moment, they can also join as PNMDP regional trainee representative. And for that also you can email us or inbox us at our Facebook page. And this is the last 10 or 15 days are left. You can also, all of those who are interested in taking part in this interesting case competition, last date is 30th of March. You guys can send in your entries and you become a part of it. And I'll post the link for today's survey in the chat box. You can fill it in the end. So thank you. Now I welcome Dr. Waseem Jamalvi, and it is a great honor that he has taken out time for us, and he'll be talking on the approach to children with COVID-19. And I'm sure obviously all of you must be waiting for this session. This is the first session on this topic on behalf of PNMDP. And Dr. Waseem Jamalvi, all of you know him very well. I don't think any one of you will not be knowing him, but for as a protocol, you know, he is the AP at Dr. Ruth KM Civil Hospital Karachi, and he's also General Secretary of the Pakistan Pediatric Association. He's a renowned personality. You must be knowing, all of you must be knowing him. I welcome you, sir. Sir, you can please unmute your mic, and you can also share your screen now. Assalamu alaikum, Dr. Waseem.
Walaikum assalam.
How are you, sir?
Allah ka shukr hai, that's very fine. What about you? And good afternoon to everyone.
Yes, sir, we are good.
Shall we start?
Yes, sir, you can share your screen and you can start off.
You stop your screen sharing?
I have stopped. You can share it now. I'll tell you when it's visible, okay?
You all see my screen? Okay, fine. Let's start with the COVID-19 in children. There is some problem in few slides. They can change spontaneously. I don't know why. Maybe there is some time setting. Kiran, you hear me clearly? Kenan?
Yes, sir, I can hear you. You can
Okay, fine.
continue.
That means
And your
everyone is here.
screen is also
Okay,
visible.
okay.
You can continue.
The COVID-19 in children, you all aware of that? The COVID-19 is a pandemic disease all over the world, and everyone is gone through of this disease. I don't know, everyone is having, or somebody is having this disease and gone through the different steps of this disease. But the children, you all know, although the children is involving with disease is very low in number all over the world, the data suggested all these things we can discuss later on. But one thing I said, that recently in Pakistan the NCOC said almost in between 1 to 10 year of age, the 38 children died because of this lethal disease. So the, everyone knows okay, how the COVID-19 in children, what are the different presentation, and when we suspect, the most important thing, the when we suspect and how can we go through this disease. And one and the most important thing in this disease is what, how can we manage and suspect in units. That is a very difficult task for us as a pediatrician and an immunologist. So let's start with this disease. You all know, okay, this is the SARS-CoV-2, and previously there are. This is a coronavirus. You all aware of that? The coronavirus, and the coronavirus not the first time isolated, and this disease was basically isolated in 60 years back in 1960. 59 and 60 with the coronavirus, and there were two endemic of this disease in 2003 and 2013 with the name of SARS and the MERS, and with the same presentation of the acute respiratory illness. But this time this COVID started from the Wuhan. You all aware of that. But the one and the most important thing, the children, the less than 5% of the children are having this disease. And fortunately, it's a good for the children and the pediatric that more than 75% of the children are asymptomatic. You all aware that this is the very rarely they can be transmitted droplet, but usually it is transmitted by the contact transmission, by touching the contaminated surfaces like fomite and tissue paper, used tissue paper, doorknobs, and everything, whatever it is. And the mean incubation period of this disease is usually is 5 days, but the duration is between 0 to 14 days. This data was updated on 14th March, 3 days back, and globally there were the 119 million person having this disease, and out of that, the more than 2.6 million died because of this lethal disease. And the local data is no doubt very low. The more than 6 lakhs persons are affected, and out of that, the more than 13,000 died because of this disease. So just look at the epidemiology. You all aware of that. This is the community transmission disease, and you all aware of that. This is the international pediatric data suggested that the COVID-19 is low in low rate of effectivity in the children, it is the important thing. If a child who is the younger than the 1 year of age, the 1 year of age can be presented with the severity of this disease, and he may need the hospitalization or the specific care of the different presentation. And more than 50% of the children are having this disease. As you know, previously the schools are off and everything was closed, and usually the children at home. So the disease usually they can get from the family members. So the one and important thing is the family data is very important. And median interquarantine time, the development of the symptom and the severity of this disease in younger age is 2 days, and the range is 1 to 5 days. But in elder person, elder adolescents or older children, this age time is around 4 days, and the range is 2 to 7 days. The 80% of children, 80% of the children are having this disease with the history of fever, and more than 65% children can present with the upper and lower respiratory tract symptoms. So these are the two main presentation of this disease. But the certain other atypical presentation like the CNS involvement of CNS, seizure or seizure-like activity, different GIT symptoms like the diarrhea and vomiting, and sometimes they can be present with the generalized septicemic like presentation, or maybe there is some cardiac involvement as well. So there is the multiple presentation of this disease they can present to you with the COVID-19. But when you suspect the COVID-19 in children, these are the presentation. Usually, they are presentation. These presentation are very common in a pediatric age group, and we commonly see these type of the symptoms in the children. But when we suspect, this is the important thing, and this is the epidemiological criteria for the suspectation of this disease. And any child who comes to you, as you know, if there's more than 80% children can present with the fever, and more than 65% children can present with respiratory involvement. So there should be the any one of the epidemiological criteria can be present. Yeah, and these epidemiological criteria is what that there is the contact of the confirmed of the suspected case of the COVID-19 is last 14 days. This is the most important thing. Number two is either they can attend a mass gathering like shadi or everything, and a social functions and a festival, with a person who is suspecting of COVID-19 or confirmed case of COVID-19. But in small gatherings like a school classroom or the home gathering, small home gathering, offices, meeting room, even sometime in the hospital waiting area, there may be okay. Okay, Kiran, और जोर से बोल देता हूँ, they can be if there is a two or more cases of respiratory symptom, if they are presented, if they are present in that small gathering, then this is the suspected this is the case for suspected case for the COVID-19. And one thing is more important, that the hospitalization or attending the any hospital facility or the waiting room in the last 14 days prior to the starting this presentation. These are the main epidemiological criteria. They should be present in the suspected case for the COVID-19. The simultaneously, you all know if there is the some underlying chronic medical condition like heart disease, or the child is having lung disease or chronic kidney disease, or the child is some immunosuppressive drug, there may be chances to flare up of this disease. And one thing is the absence of any other etiology that fully explain the clinical presentation. These are the different types of the suspectation. And if anyone is present, then you can suspect the COVID-19 of this children.
नाम
So
बोलो
any who comes to you, Kiran, can you
वालिद का नाम बोलो
think of other people? There is some
कितने दिन
disturbance.
से बारिश हो रही है कितने दिन से हो रही है
And it is requested everybody to please mute your mic. So you can unmute your mic.
If the any child who comes to you in the triage, the algorithm is what? How can we remove this? Please move this window away from the shared application. Okay. The any child, if he come to the if he come to the uh, ER, or there is, if you suspect the case of COVID-19, then you register, and then you can be categorize this child, either this child is the sick or the stable. In the sick patient and a stable patient, if you are suspecting this case of COVID-19 with the epidemiological criteria and the certain signs or the symptom, then you can send the PCR. If the PCR is turned out to be negative, okay, fine. But if it is positive, then what can we do? So isolate this child either at home or at the hospital facility. Uh, hospital, whatever it is. But the second most important thing we should is clean the all close contact, especially at home. If this patient at home quarantine. This is the criteria for the stable patient. Like the patient is having the fever, cough, body ache, flu, or sore throat, but there is no tachypnea or difficulty in breathing. So we should isolate at home, and we can follow this child and monitor everything. And if this child is getting sick during the isolation, either at home or at the hospital, then we can repeat the PCR. And if PCR is again turn out to be negative, that means okay, we can switch to this patient out of corona ward and we manage accordingly of that specific disease. But if at this moment, if this turn out to be positive, then we got admit in the corona setup, and we categorize this child according to the presentation. So at home, what can we do at home? We should be isolated, rest, monitor temperature, and only antipyretic is given, and there is a strict hand washing, and use the everything, and use, I think ये slide क्यों आ रही है बीच में? Please move this window away from the shade of the patient. ये क्यों आ रहा है? किरण, आप दस से तो कोई नहीं. Is everybody seen the mic पे से?
यस सर, ये
Yes,
डिस्टर्ब
sir,
कर रहा है, ये आ रहा है.
क्या
तो
चीज
ये
है
थोड़ा
क्यों?
सा थोड़ी देर बाद चला जाता है, लेकिन थोड़ा इसको आप बैक क्लिक करके कोशिश करें रिमूव करने की. बैक
कैसे
क्लिक
करें?
करें. नहीं, ये तो एंड शो है. नहीं,
डिस्टर्ब कर रहा है ये, असल चीजों को तो छुपा रहा है ये बेचारा.
मूव भी नहीं हो सकता.
Move this window away from. Okay, fine. We can continue with
With
this.
time it disappears basically.
सर इस पे जाके क्लिक करें इसको बैक से, और फिर हो सकता है रिमूव हो जाए.
कर तो रहा हूँ मैं, क्लिक करता हूँ तो ये आता है, अगर मैं लेफ्ट क्लिक करता हूँ तो कुछ भी नहीं होता है. दूसरी स्लाइड आ गई.
रहने दें फिर.
छोड़ देते हैं, ठीक है. अच्छा, okay, fine. And there is no role of steroid in the children at the go home type of management, and the child should be isolated. And when we discontinue the isolation, either the child is asymptomatic for the 3 days or 10 days after the positive PCR, whichever comes later next. So this is the danger sign. Look at this, and the sick patient criteria. These are the almost 8-9 criteria. Yeah, it should be looked, and any one criteria is present in the child with the suspected case of COVID-19 should be suspected as a case of the sick patient, and these are called as IMNCI is the danger sign in the corona cases, like severe dehydration, either the child is lethargy or dull, decreased conscious level or unconscious. There may be the seizures, irritability, or excessive or uncontrollable cry, central cyanosis, grunting, chest indrawing, the fast breathing, saturation less than 92% on rooming. There may be of certain cardiac involvement like the heart attack. This is not from my side. Or heart failure or myocarditis, and certain signs of the shock. So, if anyone, danger sign is anyone danger sign is present in a suspected case of COVID-19. Even you look at on the right side. Okay, if you look at just look at the respiratory rate, and that is according to the IMS, a very simple way to suspect corona and start management. And if you look at the respiratory rate 60, 15, 40, and more than 5 years, this 30, then you can admit this child, whatever the corona facility, and send the PCR. And if PCR is turned out to be negative, then this child should be move out of the corona facility and manage accordingly as per his or her diagnosis. But if the PCR is positive, then this child should be got admit in a corona facility, and we can move for the further investigation. And the definition of the contact. What is the definition of contact? The previously we listened for the epidemiological criteria, and this is the contact. A person living in the same household where there is a confirmed and a suspected case of COVID-19 with the direct physical contact, like usually the shake hand or whatever it is, or having the most important thing is unprotected direct contact. Unprotected direct contact means that with the bare hand you can touch the different bar doors and doorknobs or the used tissue paper, whatever it is. Then this is the history of contact, or and this is the most important thing, the face-to-face contact within the 1 meter for more than 15 minutes. So there is a three things important, like the unprotected face-to-face contact of less than 1 meter for more than 15 minutes. Then this is called the history of contact with the COVID-19. So there is the two words we use, the suspected and a confirmed. Suspected means there is a history of some sign, symptom, and a sign like the respiratory symptoms, a fever and a cough, with the epidemiological criteria or history of contact. But in case of confirmed case, there should be the laboratory confirmation irrespective of sign and symptoms. So if a child who comes to you, how will we investigate, and what different investigation we gone through of these children? अब हम इसमें अगर देखें तो these are very common test is what is the PCR, and the PCR is what यार कैसे जाएगा? अब ये एक नई चीज आ गई. ये हमारी तरफ से नहीं है भाई. Okay, fine. This PCR, the name of this PCR is basically nucleic acid amplification testing, NAT test, and the actual name is not the only PCR, the real-time reverse transcriptase polymerase chain reaction, but there is the certain chances of the false negative, and in the false negative, then there is the poor quality of a specimen collected late or very early of the infection, improper transport or storage, or maybe there's some technical reason. If you strongly suspect that there is this child is having the COVID-19, then you can repeat from the some other specimen from the maybe the taking from the lower respiratory tract, if possible, should be collected and tested if you are strongly suspect the COVID-19 and there is PCR negative. अच्छा, यहाँ पे एक छोटी सी वीडियो मैं चलाना चाहूँगा, अगर वो चल गई तो just wait for a couple of seconds.
This is a video in clinical medicine from the New England Journal of Medicine.
आवाज आ रही है किरण?
सर आ रही है.
Okay, fine.
Collecting specimens from the surface of the respiratory mucosa with nasopharyngeal swabs is a procedure used to diagnose COVID-19 in adults and children. The procedure is also commonly performed to evaluate patients suspected of having other respiratory viral infections or certain bacterial infections. This video describes collection for detection of COVID-19. There are no specific contraindications for collecting specimens with nasopharyngeal swabs. However, clinicians should be cautious if the patient has had recent nasal trauma or surgery, has a history of a markedly deviated nasal septum, chronically blocked nasal passages, or severe coagulopathy. Nasopharyngeal swabs are specifically manufactured to have long, flexible shafts made of plastic or metal and tips made of Dacron, rayon, or flocked nylon. It is essential to put on personal protective equipment, or PPE, correctly. and to follow the pertinent respiratory and contact precautions according to both the Centers for Disease Control and Prevention, or CDC, and by your institution. If possible, you should put on and take off PPE in the presence of an observer to make sure that there are no breaks in technique that may pose a risk of contamination. First, put on a protective gown and wash your hands with soap and water, or use an alcohol-based solution. And put on a pair of non-sterile gloves, followed by a protective mask with a rating of N95 or higher, as recommended by the CDC. Finally, put on a face shield for eye protection. All sample tubes should be labeled and the appropriate requisition forms filled out before starting the procedure. Masks are recommended for all patients suspected of having COVID-19. Have the patient take off her mask and blow her nose into a tissue to clear excess secretions from the nasal passages. Remove the swab from the packaging. Tilt the patient's head back slightly so that the nasal passages are filled. Ask the patient to close her eyes to lessen the mild discomfort of the procedure. Gently insert the swab along the nasal septum, just above the floor of the nasal passage, to the nasopharynx, until resistance is felt. If you find resistance to the passage of the swab, back off and try reinserting it at a different angle, closer to the floor of the nasal. Or metal, and tips made of Dacron, rayon, or flocked nylon. It is essential to put on personal protective equipment, or PPE, correctly, and to follow the pertinent respiratory and contact precautions according to both the Centers for Disease Control and Prevention, or CDC, and by your institution. If possible, you should put on and take off PPE in the presence of an observer to make sure that there are no breaks in technique that may pose a risk of contamination. First, put on a protective gown and wash your hands with soap and water, or use an alcohol-based solution, and put on a pair of non-sterile gloves, followed by a protective mask with a rating of N95 or higher, as recommended by the CDC.
हेलो किरण, वो आपकी तरफ से पॉज आ रहा है, स्क्रीन शेयरिंग इज पॉज्ड, क्यों आ रहा है?
This is a video in clinical medicine from the New England Journal of Medicine. Collecting specimens from the surface of the respiratory mucosa with nasopharyngeal swabs is a procedure used to diagnose COVID-19 in adults and children. The procedure is also commonly performed to evaluate patients suspected of having other respiratory viral infections or certain bacterial infections. This video describes collection for detection of COVID-19. There are no specific contraindications for collecting specimens with nasopharyngeal swabs. However, clinicians should be cautious if the patient has had recent nasal trauma or surgery, has a history of a markedly deviated nasal septum, chronically blocked nasal passages, or severe coagulopathy. Nasopharyngeal swabs are specifically manufactured to have long, flexible shafts made of plastic or metal and tips made of Dacron, rayon, or flocked nylon. It is essential to put on personal protective equipment, or PPE, correctly, and to follow the pertinent respiratory and contact precautions according to both the Centers for Disease Control and Prevention, or CDC, and by your institution. If possible, you should put on and take off PPE in the presence of an observer to make sure that there are no breaks in technique that may pose a risk of contamination. First, put on a protective gown and wash your hands with soap and water, or use an alcohol-based solution. And put on a pair of non-sterile gloves, followed by a protective mask with a rating of N95 or higher, as recommended by the CDC. Finally, put on a face shield for eye protection. All sample tubes should be labeled and the appropriate requisition forms filled out before starting the procedure. Masks are recommended for all patients suspected of having COVID-19. This is a video in clinical medicine from the New England Journal of Medicine. Collecting specimens from the surface of the respiratory mucosa with nasopharyngeal swabs is a procedure used to diagnose COVID-19 in adults and children. The procedure is also commonly performed to evaluate patients suspected of having other respiratory viral infections or certain bacterial infections. This video describes collection for detection of COVID-19. There are no specific contraindications for collecting specimens with nasopharyngeal swabs. However, clinicians should be cautious if the patient has had recent nasal trauma or surgery, has a history of a markedly deviated nasal septum, chronically blocked nasal passages, or severe coagulopathy. Nasopharyngeal swabs are specifically manufactured to have long, flexible shafts made of plastic or metal and tips made of Dacron, rayon, or flocked nylon. It is essential to put on personal protective equipment, or PPE, correctly, and to follow the pertinent respiratory and contact precautions according to both the Centers for Disease Control and Prevention, or CDC, and by your institution. If possible, you should put on and take off PPE in the presence of an observer to make sure that there are no breaks in technique that may pose a risk of contamination. First, put on a protective gown and wash your hands with soap and water, or use an alcohol-based solution. And put on a pair of non-sterile gloves, followed by a protective mask with a rating of N95 or higher, as recommended by the CDC. Finally, put on a face shield for eye protection. All sample tubes should be labeled and the appropriate requisition forms filled out before starting the procedure. Masks are recommended for all patients suspected of having COVID-19. Have the patient take off her mask and blow her nose into a tissue to clear excess secretions from the nasal passages. Remove the swab from the packaging. Tilt the patient's head back slightly so that the nasal passages become more accessible. Ask the patient to close her eyes to lessen the mild discomfort of the procedure. Gently insert the swab along the nasal septum, just above the floor of the nasal passage, to the nasopharynx until resistance is felt. If you find resistance to the passage of the swab, back off and try reinserting it at a different angle, closer to the floor of the nasal canal. Insert the swab into the nostril, parallel to the palate. The swab should reach a depth equal to the distance from the nostrils to the outer opening of the ear. The CDC recommends leaving the swab in place for several seconds to absorb secretions, and then slowly removing the swab while rotating it. Your institution may also recommend rotating the swab in place several times before removing it. Ask the patient to reapply her mask. Open the collection tube and insert the swab into the tube. Break the swab at the groove. Discard what remains of the swab. Wipe the sample tube with a surface disinfectant wipe and insert the tube into an open bag held by an assistant. The sample may also be returned to its original packaging for transport, depending on institutional practices. Follow the CDC directions for direct processing of the swab specimen or placement of the swab in media with or without refrigeration. Remove your personal protective equipment as shown here, or in accordance with the standards at your institution. First, remove your gown and gloves. Then clean your hands with an alcohol-based solution or soap and water. Put on a new pair of gloves and then remove your face shield and dispose of it, or clean and store it, in accordance with the guidelines at your institution. Remove your gloves. Rewash your hands and put on another pair of gloves. Then, remove your mask and follow your institutional guidelines for disposal or reuse. Finally, remove the last pair of gloves and wash your hands. This video has demonstrated how to collect specimens from the surface of the respiratory mucosa with nasopharyngeal swabs in order to diagnose COVID-19 in adults and in children. As shown, it is important to use approved PPE and the appropriate technique to minimize the possibility of spreading the virus.
Presentation. Okay. हाँ इसको बंद करें और वो लगा दें शेयर नीचे नीचे और नीचे और नीचे और नीचे Okay, fine. You all saw the video. Now we move over. There is three things you can check in your this video. There is the how can we take the specimen of naropharyngeal swab in the adult, even in the children, is the same process. And the most commonly the false negative is because of that we can hold it for the 20 seconds into the nose, and then we can move it, and then we remove. If there is some problem in that, then we have a false negative of PCR test. But if we are strongly suspect that there is some negativity, and we can repeat by taking some other specimen from the lower respiratory tract, or we can go for the serology as well to confirm that this is a case of COVID-19 or not. So this slide is very important. If you look at over here, this is the time when the symptom started. So before the symptom started, if you look at of the blue line, the maximum range in not on the same day, but on the second or third day after starting the disease, and then there is a 2 weeks time, then you can find the positive PCR test, and then there is the decrease. But at the moment, you can check the virus isolation from the other part of the respiratory tract, like the lower respiratory tract, before the symptom started, and it can be down after the first week of the presentation. But if we look at the bronchoalveolar lavage or sputum for PCR, that is the purple line, and they can be ranged almost the same for the PCR test from the nasopharyngeal. The peak time is around 2 to 3 days of development of the symptom, and that it can be down gradually after the 3 weeks. 3 weeks. But there is the antibody production of this disease, IgM and IgG, and that can be started the production of this after the first week of the disease, when there is virus isolation from the other respiratory tract, then IgM and IgG can be increased, and up to the middle of the third week, it maximally can range maximally on the middle of the third week, and then they gradually down of the IgM, but the IgG for the longer period. But still we don't know for how long we can get the IgM and IgG from the natural immunity. But one thing is important, that usually after the third week of the disease, we usually get the PCR negative, and after the third week the PCR likely to be negative. And the positivity time in the first 3 weeks and before the disease started, just 2-3 days before that disease started, till the third week of the presentation. This is the very commonly with the PCR positive from the nasopharyngeal swab or from the other part of the different. But the one thing is important, you can get the PCR positivity from the stool as well. Not that it's a very good test for the diagnosis of the corona, but there may be some stool, some virus present into the stool, and you can get the virus from the stool as well. So the other prognostic markers are the different, and if a child who gets serious or has a severe infection, then you can go for the certain other tests like the hematology, the CBC. In the CBC, the lymphocytes is low, and up to the 80% of the cases you can get the low lymphocyte count, and a platelet count usually less than 100,000, and the NL ratio is around more than 3.13%, and that is the more prognostic marker. And the acute phase reactant like the CRP, procalcitonin, and ferritin all are high, with the interleukin 6 in the certain type of the presentation of COVID-19 we discuss later on. And the other chemistry like ALT-AST, CPK-LDH, urea creatinine, and the albumin and the IL-6 is high, but the albumin is low. And these are the different presentation, like the urea creatinine usually high when there is a kidney involvement. When there is the rhabdomyolysis, then the CPK is involved. And if there is the hepatic involvement, then we can okay, fine. We can get ALT, AST is 5 times higher than the normal. In the certain hemostasis process, then there is a D dimer is high, or the PT can be high. But if there is the cardiac involvement, then the troponin I is usually high in this type of presentation. So these are the different prognostic markers in the involvement of the different part of the body, or if there is a systemic involvement, the all should be checked. So the other test is the X-ray, X-ray chest, and in the X-ray chest, the uncommon presentation they may be presented in the COVID-19 is the effusion, cavitation, mass, or lymphadenopathy. They can be, but the typical presentation is the patchy ground glass appearance of opacity in the periphery of the lung or in the base of the lung. These are the typical presentation of the X-ray, and the same for the CT scan. But the CT scan, okay, find the in adult, it is a diagnostic tool for the COVID-19, but in the pediatric age group, it's not for the diagnostic, and because initially it cannot be presented as shown as the in the adult, but there may be the same presentation of the X-ray chest, and there is the patchy ground glass appearance, and there is in the periphery or in the base of the lungs, and it is only considered in sick children where the suspected alternative diagnosis. This is the ultrasound, and the lower side of the slide of the C and D, and you look at these two ultrasound, and ultrasound is the one criteria of the diagnosis of these pneumonias, and there's a multiple studies done because of the diagnosis of the pneumonia in the children by the ultrasound, because of the children should be away from the radiation and reducing the unnecessary radiation. You can go for the ultrasound of the chest. So how can we manage the children of COVID-19? So in the management, there is the two most important thing. What is the diagnostic criteria, and how will we manage? So in the diagnostic criteria, we can categorize the COVID-19 in two categories. Number one is the asymptomatic, and number two is the symptomatic. Asymptomatic, okay, fine, but confirmed case with the PCR positive, but no clinical sign and symptom. Okay, this is the asymptomatic. But in the symptomatic, we can categorize in the three different types, like the mild, moderate, and a severe variety. In the mild variety, there is, as I previously told you, that child is called as a stable child. And in stable, there is the presentation, the certain presentation like the fever and a running nose and an everything and a body ache, but there is no radiological signs or the clinical sign of pneumonia. Then you and there is a confirmed case of COVID-19, then you call this is the mild. And the moderate and the severe, then the one important thing to divide into two, the child can present with, okay, fine, with the respiratory distress and all this, definitely with the fever and all these things, with the confirmed case of with the COVID-19 by the PCR. But in case of the if there is danger sign is present, then you label it, this is the severe variety of COVID-19. But if there is a no danger sign, then you label it, okay, this is the moderate type of variety. So how can we manage? Asymptomatic, as I previously told you everything, how can we get that home care, and the same for the management in the mild variety. But the one important thing in the mild variety is you can go for the certain investigation, especially two investigation, that apart from the PCR, if the PCR is positive, then the two important thing is number one is the CBC, and the number two is the chest X-ray. But you can go for the culture as well, because we are living in an endemic area of the different infections, bacterial infections. So you can go for the and rule out the bacterial infection as well. And in case of the moderate type of COVID-19, okay, fine, you can get admit in the isolated room or whatever. If the isolated room is not available, then the two patients should be apart from the minimum 2 meter distance, not across the infection, and send the all investigation, which I previously told you. But the one thing is important, you should be ruled out the H1N1 type of influenza and the certain other co-infections. And nebulization is not recommended because it can be aerosol forming problem, and there may be chances of spread the infection to other side. And then the antibiotic can be started if you suspect there is a secondary bacterial infection, and the baseline treatment is around the ampicillin, or in the area where the ceftriaxone you can start starting. But in case of the severe type of COVID-19, that means the only one target is what we can make the saturation of more than 92%, and manage the airway and oxygenation therapy, and all these things previously, like the all investigation, rule out H1N1, the everything. But and the empirical antibiotic should be given. The certain other drugs like the leponavir, ritonavir, the chloroquine phosphate, hydroxychloroquine, interferon therapy, and the other investigational drug are still in investigation. But the recently, the two stages I gone through, the remdesivir is some effect in anti corona disease, for the treatment of this disease, the remdesivir. And number two, you can start with the low dose of steroid in moderate and severe type of COVID-19. And there is a 38% of the children who has having the moderate and severe type of COVID-19, and there is a 38% of children can recover safely from that lethal disease. So if there is definitely the azithromycin should be avoided, and it is not the rational the use of azithromycin. Definitely there is a one word we are using around, that is the MISC, the multi-system inflammatory syndrome in children. And there is the definition criteria by WHO is that the child should be less than 19 years of age and a fever for more than 3 days, with the certain things that are very mimic to the Kawasaki disease, like the rash or bilateral non-purulent conjunctivitis, mucocutaneous inflammatory sign, hypotension, in feature of the myocardial dysfunction or the cardiac involvement mechanically or by the echo confirmation, or there is a tropin or anti-proBNP is positive. Then there is the evidence of the coagulopathy like the PT or elevated D dimers, or there may be some GI symptom like the vomiting, diarrhea, or abdominal pain. And out of these five, any two should be present with the all in high acute phase reactant, like the all inflammatory marker like ESR or CRP or prolactin, whatever is raised, with the no other diagnosis like the staphylococcal or staphylococcal shock syndrome, and there is definitely the COVID-19 is positive. Then you can think of there may be MISC, and the MISC is how can we treat, and the treatment is very mimic to the and Kawasaki disease, or if there is no Kawasaki disease, then there is for the management of Kawasaki disease, is you all know and aware of that, the IVIG aspirin and the steroid. But if it is non-Kawasaki, then there is definitely the IVIG steroid but there is a chance of tocilizumab. It is still in the investigational process, but the few studies said there is a very good response by this disease, this drug, but it is in the new rationale of the use of the tocilizumab. Okay, fine. The Kawasaki disease, you all aware of that. There is the classical Kawasaki disease, and at least four of the following different things. And out of these five, the four should be present. But in case of the minimal Kawasaki disease, then or atypical Kawasaki disease, there is at least two or three with the cardiac involvement. Uh, with the cardiac involvement. One thing is CRS, that the cytokine release syndrome, and this is the acute systemic inflammatory syndrome, and it is basically because of the multi-organ dysfunction. Usually, it is because of the Ebola and influenza virus, but the one drug we are using in the management of the COVID-19, that the rituximab, they can be a side effect of this drug, and there is the increased level of inflammatory cytokines, that is the T lymphocyte, macrophages, and endothelial cells, with the presence of the moderate to severe COVID-19 disease, and that is the raised ferritin, CRP, LDH, or D dimer with the interleukin 6, and definitely the low level of the lymphocyte less than 20%. And you are aware of that there is this is a life-threatening disease, and is in this stage, this is the management is the steroid and the tocilizumab, that is the Actemra, or you can use it with the dose of if the child is less than 30 kg, 12 mg per kg, or more than 30 mg, then the 8 mg per kg, the maximum dose of 800 mg IV. And if you repeat it after 12 hours, if there is no clinical improvement. So there is some clinical scenario, and you can discuss clinically, okay, how can we think. Anybody can answer or raise their hand. I can check. Okay, fine. I'll wait for a couple of minutes for Azan.
Anybody wants to volunteer?
Sir, may I reply, Dr. Geeta?
Yes, sure, Dr. Geeta.
In this case, when a mother brings up a positive case of the PCR, first we examine the child, and we see it becoming the categorized mild, moderate, and severe. If it becomes the mild, and if he has only cough, low-grade fever, and flu, then we admit in ward or to send home with precaution measures. If patient then fall in the
Sorry Geeta, wait for a couple of minutes more. Azan हो रही है, बस थोड़ा सा wait कर लें. Azan खत्म हो जाए, then we start. Geeta, open your mic. Open your mic.
Okay, sir. Should I start?
Just a minute, मैं बताता हूँ. Ji, start. An anxious mother has brought her 4-year-old girl with the ER to the COVID-19 PCR positive result. बच्चे का PCR positive है. Then what is your approach for this case and how will you manage? जी.
सर, इसमें हम पहले तो आइडेंटिफाई करेंगे कि ये बच्चा एसिम्प्टोमेटिक है. हमने बच्चे को एग्जामिन करेंगे, जो रिपोर्ट लेकर आई है, तो हमें अभी ये कंफर्म केस है कोविड का, तो हम इस बच्चे को ना देखेंगे एसिम्प्टोमेटिक है, सिम्प्टोमेटिक है. अगर ये बच्चा सिम्प्टोमेटिक है तो फिर हम इसमें फर्दर कैटेगराइज करेंगे कि ये माइल्ड है, मॉडरेट एंड सीवियर है. ठीक है, अगर ये बच्चे को माइल्ड कैटेगरी में फॉल कर रहा है जिसमें उसको लो ग्रेड फीवर कफ एंड फ्लू है, देन तो फिर हम उसको जो है ना घर भी भेज सकते हैं, या फिर हम उसको हॉस्पिटल में अगर फैसिलिटीज है तो उसको जो ना आइसोलेट कर देंगे मदर के साथ।
ओके फाइन, दैट्स गुड। अक्सा, यू कैन ऐड समथिंग। आपने माइक ऑन किया हुआ है।
यस सर। सर माइल्ड मॉडरेट और सीवियर ही था कि माइल्ड में जो है वो आपको मिलेगा कि फ्लू है बच्चे को, या लो ग्रेड फीवर है, कफ है।
Very good. And one thing should be tell to the parents, a parent or the caregiver is the danger sign.
डेंजर साइन सर हम पूछेंगे उनसे ना, और हम देखेंगे बच्चे के अंदर कोई लेथार्जिक है, कन्वर्जेंस है, डिहाइड्रेशन है, शॉक के साइंस है उसमें।
Shall we go the next case? Shall we go for the next case? A 6-month-old boy presented in the ER with a fever and a cough for last 3 days and difficulty in breathing since last 4 hours. On clinical examination, this child is active and alert with a fever of 102 degree Fahrenheit. The heart rate is 140, respiratory rate 40 breath, and the blood pressure is 82/50, and oxygen saturation is 94. Just there is a bilateral cleft, but the rest of the system examination unremarkable. The CBC shows that the HB is 10 and the TLC is 6.9, and out of that the neutrophil is 72% and the lymphocyte is 21. The platelet is 241 and the CRP is 0.05. The blood culture is pending, okay fine, and the blood chest X-ray shows there is a non-homogeneous obesity on bilateral. आपको यहाँ नजर आ रहा होगा, समझे कर दें, the bilateral non-homogeneous opacity on the periphery of the lung. And the COVID-19 PCR is negative. That is done by 2 days back. What is the approach of management in this children? In this child, okay, sorry. Anybody? Anybody answer? Anybody?
Anybody wants to answer can raise their hand.
Or can open their mic by themselves and
Yes.
start giving answer, and Ashok, Wajia, Uruj, anyone? Shazia Meher, Shaheen. Okay, fine.
सर इस वाले बच्चे को क्योंकि इसमें आपके डिस्ट्रेस के साथ आया है और एक्सरे में फाइंडिंग भी मिल रही हैं, तो ये ऑल्दो इसका पीसीआर नेगेटिव है, हम इस बच्चे को फिर भी एडमिट करेंगे और इसको हम कोविड वार्ड में रखेंगे, और इसके हम
गो फॉर द एडमिशन। गीता, हम इसका जो है ना पहले एपिडेमियोलॉजिकल क्राइटेरिया को फिट करने की कोशिश करेंगे ना, इफ देयर इज द एपिडेमियोलॉजिकल क्राइटेरिया इज प्रेजेंट और नॉट। इफ द एपिडेमियोलॉजिकल क्राइटेरिया को देखेंगे, शाजिया यू कैन ऐड समथिंग, शाजिया मेहर।
सर इसमें सर एक्चुअली इसमें 92% इसकी सैचुरेशन आ रही है, तो सैचुरेशन तो मेंटेन कर रहा है, सीम्स टू बी स्टेबल। हम इसे घर भेज सकते हैं कि हम उनको डेंजर साइंस से बताकर और उनको सारा
सस्पेक्टेड है या नहीं है उस पर देखेंगे। सस्पेक्टेड केस है कि इसकी हिस्ट्री लेंगे, इसकी हम हिस्ट्री लेंगे, ये कि सस्पेक्टेड केस है कि नहीं है, कॉन्टेक्ट ट्रेसिंग करेंगे। अगर सस्पेक्टेड है, कॉन्टेक्ट डिजीज है, तो फिर हम उसको एज ए माइल्ड टू मॉडरेट लेंगे, इसको आइसोलेट करेंगे। और सीबीसी तो शो कर रही है कि इसका जो है ना वो न्यूट्रोफिल टू लिम्फोसाइट रेशियो जो है वो भी ज्यादा हो रहा है।
What can we do for PCR? What we do for PCR? PCR negative means that this is not corona, this is not COVID. Then what can we do?
We can repeat PCR.
PCR को repeat कर सकते हैं।
Sir, we will monitor, or if a patient becomes sick, then we can repeat PCR.
Yes, and on the repeat PCR, it is positive. Then what can we do? Then the category is the moderate COVID-19, and the moderate COVID-19 means that we manage this child according to the management of the moderate variety, like we rule out the H1N1 and we start management with the empirical antibiotic, IV hydration, and all these things. If this child getting improved, then we plan for discharge of 3 weeks time or 10 days time. Okay, fine. The third case is 6-year-old boy presented to ER with a fever and a cough since 3 days and a history of diarrhea and vomiting and a pain in abdomen and difficulty in breathing for last 4 hours. On examination, dull and lethargic, temperature of 102 and a heart rate is 170 and a respiratory rate of 70. Blood pressure is 65/40 and the saturation is very good, 94 on room air. but the capillary refill time is more than 3 seconds at the cold periphery. The chest is bilaterally cleft is present and the slight lever is palpable. The CBC shows this. The hemoglobin is 10 and the TLC is 4.9, and the same in the previous report, like 72% of the neutrophil and 21% of the lymphocytes. The CRP is positive of 40, and the blood culture is definitely pending on. There is the cardiomegaly. If you look at, there is the cardiomegaly in this child, but again the PCR is negative. So what can we do? G. Anything else? Anybody?
So, so first of all, like you asked, what points we will like to ask in the history? We will like to do the epidemiological tracing of the patient, like if he has a
Good.
travel history, if he has any contact with
That
COVID-19
is
who is positive,
good, good,
or
good.
if he has any person who is even COVID-19 negative with signs and
Very
symptoms
good.
of COVID-19. Next, we
Like
will
the epidemiological criteria, you excluded by the adding the epidemiological criteria. If
okay.
ठीक है, epidemiological criteria is present, then you can put this child into the corona, label the corona. And if you suspect, strongly suspect the COVID-19, then you can repeat the COVID-19. And if it is turned out to be positive, then you can manage accordingly. लेकिन इसमें एक चीज देखें आप कि इसमें जो है कार्डिक इन्वॉल्वमेंट भी है, कार्डिक इन्वॉल्वमेंट भी है, जिसका मतलब ये है कि either this is the और कार्डिक इन्वॉल्वमेंट भी है, डल है, और तीन चार चीजें इसमें प्रेजेंट हो रही हैं. That means कि this is a case of MISC. And if this is the case of MISC or the cardiac involvement, then you can manage accordingly and very aggressively manage. ठीक है, देखिए इसमें यहाँ पे शो भी किया है इन्होंने कि PCR 2 दिन बाद करवाया था and that turned out to be positive, and there is the lymphopenia and the CRP and tropin is high, so you can manage accordingly according to the management of MISC. ठीक है, उसको हम आगे चलते हैं. The one and the most important thing, the COVID-19 and newborns. ये बड़ा important सवाल है कि how can, when we suspect the COVID-19 in newborn, एक बेबी डिलीवर हो रहा है हमारे पास आया है, तो हम क्या करेंगे ना, how can we start management and when we suspect the COVID-19. So the suspectation of the COVID-19 in the neonate is the baby born with a mother of history of COVID-19 in 14 days before the delivery and the 28 days after the delivery, or there's a neonate history of exposure to a person who is suspected or confirmed case of COVID-19. And there is the confirmed COVID-19 means definitely the PCR, the NAAT test is positive, the real-time reverse COVID PCR is positive, then you can label it, this is the confirmed case. What is the mode of transmission? It is the droplet, okay, fine. Contact, yes, but there is the chances of the fecal-oral transmission. As you know, there is the stool is positive for the PCR as well, and maybe there is some vertical transmission. Still, studies going on all over the world for the vertical transmission, but the certain study says that there is the newborn baby is having the vertical transmission of this disease. Look at the presentation of the clinical feature of the neonate. These all are, if you look at and gone through all these all are very closely with a neonate who can present with the septicemia, temperature instability, respiratory rate problem, grunting, nasal flaring, chest cough, tachycardia, poor feeding, lethargy, vomiting, diarrhea, and abdominal distension. अगर इन सबको हम देखते हैं तो these all are like the septicemic baby. So investigation is almost the same. There is not the specific test. हम वही टेस्ट करवाएंगे जो हम करवाते हैं, the everything, and we can go for the PCR and the blood culture is important. Okay, fine. Sometime we can get the radiological finding positive, and maybe we go for the ultrasound of the chest in these children. But how can we manage in the delivery room? A mother who is COVID positive, near to delivery, come into our hospital, and you can call to attend this baby. There is a mother is COVID-19 positive. Then how can we do? So to start with this, the mother is COVID-19 positive. Then the mode of delivery is depend by the obstetrician, whatever it is, the normal delivery or the cesarean section, whatever. But the delivery should be in the separated area where the dedicated team should be where the strict PPE level 3. आप लोगों को levels का तो पता है ना PPE कि there is a 3 level of the personal protection equipment, level 1, level 2 and level 3. So level it should be where the level 3 protection, and the newborn baby should be resuscitated at different table that should be away from 2 meters away from the mother's table, and or in the separated room by the trained staff with the PP3, and properly according to the resuscitation protocol. जो भी उसका protocol है उस हवाले से manage करना है. But the neonatal management क्या है, that either the neonate is symptomatic or asymptomatic. If a neonate who is asymptomatic, then there is the different criteria. The mother is well. If the baby is suspected COVID-19, then the mother is positive but well. So the manage the designated area with the contact and droplet precaution. जो WHO के नए अभी आया protocol that said they said with the proper hand washing and wearing mask and the wash the body and especially the breast, and then he can start breastfeeding, and the child baby should be monitored 4 hourly, especially the respiratory rate, and the mother's PCR is negative, then it managed accordingly whatever it is. And if the mother is unwell, then again the manage in the designated area with the proper contact and droplet precautions and all these things. But the feeding plan should be discussed to the mother. हम उसको breast feeding protocol का भी हम discuss करेंगे क्या करना होता है इसमें. And then if the mother PCR is negative, then okay fine. But if the mother PCR is still positive, then send the infant sample of PCR in after 24 hours of age of the baby. अब बेबी का सैंपल हमने भेज दिया है. If the baby sample is negative or if it is positive, but the mother is well mother and well infant, okay fine, they should be rooming in the same room, and proper hygienic condition or proper isolation or the proper precaution by the mother, wear the mask and wash the hand, wash the body, and should be tested after 14 days, and keep an eye and monitor the baby and monitor the mother, and repeat the PCR after the 14 days. And if it is turned out to be negative, then you can manage properly. But the one important thing in examination point of view, the emotional support of the mother. आपको पता है कि जैसे ही आप किसी को बोलते हैं कि तुमको कोरोना हो गया है, तो they are emotionally depressed कि ये लोग अब मेरे साथ पता नहीं क्या होने वाला है, and my baby is having the same disease, और इतना छोटा बच्चा है इसके साथ क्या हो जाएगा. So yes, we definitely know that there should be the emotional support is very important. If the PCR is negative in a neonate, then if the unwell mother and the well infant, then the contact and droplet precaution in the both. And if the mother is having the mild disease or asymptomatic, then we can continue our contact with the ID personnel for the treatment of the baby, and the emotional support is important. But if a baby who is symptomatic, बच्चे को neonate को symptom आ रहा है, then what can we do? If the baby is symptomatic, okay, fine. The transport in the incubator to the NICU for the isolated area, and the, send the certain investigation. We all that the CBC, CRP, blood culture, serum electrolyte, LFTs, and whatever it is, and the PCR for the COVID-19 and the chest X-ray. If the infant PCR is negative, then this baby should be managed as whatever the management protocol and guidelines in that specific nursery. But if the PCR is positive, then we can manage according to the the continuously supportive treatment, watch and treat the complication, multidisciplinary team, and they start empirical antibiotics, the broad spectrum antibiotic, and so the different IV fluid and all these things as we manage these neonates as a case of septicemia. But there is certainly 7 question is very commonly asked by the doctors and the teachers as well. Is this virus teratogenic? Is delayed clot clumping is recommended? Or can mother breastfeed her baby? Can there is routine immunization or the soft palate examination be done in the newborn examination, or the newborn newborn screening, is this possible, or what are the other treatment option beside routine management? ये न्यूनेट में ये चीजें देखी जाती हैं, क्योंकि आपको पता है कि जब कोरोना नया नया आया था तो देयर इज द थ्रोट एग्जामिनेशन इज प्रोहिबिटेड in every child. If you are protected yourself, then you can go for these things. So there is no evidence, still there is no evidence that this organism is teratogenic or not. अभी तक हमें नहीं पता है. कॉट ब्लड क्लैंपिंग इज द सेम, इसमें कोई मजीद फर्दर डिले करने की या अर्ली क्लैंपिंग की कोई जरूरत नहीं है. द रिकमेंडेड टाइम इज 1 मिनट एंड वी कैन क्लैंप एट द 1 मिनट. एंड ब्रेस्ट फीडिंग के लिए yes there is the 8 or 9 steps to start with the some other milk. If the mother is suspected of COVID-19, then what can we do? If no, then we can start safely breastfeeding. If the answer is yes, then if the mother is well enough to breastfeed, yes, then start. Yes, the mother should be start breastfeeding with the wearing of the surgical mask. But if the mother is not well, so then there is the express milk, breast milk should be started. But the express breast milk is not available, then is continue the breast milk. Yes, then continue the express breast milk. And there is start breastfeeding. But there is no express breast milk, then we can be, if it is acceptable, the wet nursing. If the culture is acceptable, then we start for the wet nursing and continue with the wet nursing. But if the culturally wet nursing is not acceptable, then if there is a human milk is available, or some donor human milk bank is available, then we go for that. And if it is not, even there is no human milk available, no wet nursing, then we go for the other milk other than the mother's milk or top milk. Okay, so a very long list of all these things. This is the very important slide to start the breastfeeding, and this is the breastfeeding protocol and management. And you all know that the BFHI, the Breastfeeding Hospital Initiative, is now again started. Initially, it was started in early 80s, but gradually, with the passage of time, it was stopped. But again, it is started by the UNICEF and WHO in all the third world country, including Pakistan. ठीक है, अगर यहाँ तक नहीं आता है, उसको यहाँ तक मना करती है, then we go for the alternative mode of the feeding to the baby. These are basically 8 or 9 steps. Then you can say कि अब इस बच्चे को हम कोई दूसरा दूध दे सकते हैं. For vaccination, it is well recommended that every baby should be vaccinated. Even the WHO continue to recommend the neonatal BCG vaccination, the neonatal infant physical examination. Even you can go for the soft palate examination to check the soft palate examination of the all newborn babies. And these tests, Natasha Bintermi, the newborn spot test, this is called the Guthrie test. You all aware of that, the Guthrie test, and this is recommended, the Guthrie test. There are the certain treatment options. Apart from that, we can treat these children as a case of the septicemia. Okay, fine, we are antimicrobial use of antimicrobial drug use, but not should be overused. We are using the over drug, but immunoglobulin can be used in the severe cases. But the surfactant, yes, if there is the severe respiratory distress and a ground glass appearance, there may be used. But the certain antiviral drugs like the remdesivir, leponivir, ritonavir, and anticytokines, like ticulizumab, it is still in process. There is still no data available for the management of the neonate with the COVID-19. I'm very much thankful to the UNICEF and the WHO and the Khan University and the Pakistan Pediatric Association and the Ministry of the Health to make these slided from their sites, and very helpful for the making this slide for the guideline for the making the diagnosis and management of the COVID-19 in children. Thank you very much. Any question?
सर CRS एक दफा बता दें, CRS पे क्या क्राइटेरिया?
फिर वापस जाना पड़ेगा। अच्छा पीछे में ना मैनेजमेंट ऑफ चिल्ड्रन में है ना। This one, I'll look at this. That is basically acute systemic inflammatory syndrome. इसमें होता क्या है? Usually this is secondary to Ebola and influenza infection, but the drug which is usually using in the management of COVID-19, that is rituximab, उसकी वजह से भी इसको होता है। और इसमें जितने भी inflammatory markers हैं, especially the ferritin, CRP, LDL, D-dimer and interleukin 6 are raised. ठीक है। अब लिम्फोसाइट्स तो डेफिनेटली हर कोरोना में कम होते हैं, तो इसमें जो बच्चा जो आता है आपके पास, दे कैन बी प्रेजेंट विद द कैपिलरी लीकेज, द थर्ड स्पेसिंग, वेस्कुलर कंप्रोमाइज, आपका जो सीआरटी है दैट इज मोर देन 3 सेकंड, एंड देयर इज द कोगुलोपैथी। ये 3 डिफरेंट प्रेजेंटेशन होती है इनकी, और ये इसकी जो इन्वेस्टिगेशन होती है जो कि इसकी पॉजिटिव आती है, इट्स अ लाइफ थ्रेटनिंग डिजीज, and this is the management, either the steroid with the interleukin 6 inhibitor like tocilizumab जो Actemra हम यूज करते हैं, that is indicated in the children but still not indicated in the neonate। अभी तक इसका कोई डेटा neonate में नहीं आया है जी। any other question or any other
Sir, newborn is positive for COVID. Should we vaccinate him?
Yes, you can go for the vaccination. Vaccination को मना नहीं करना है। For
the COVID PCR positive.
Yes, whatever it is. If the baby is COVID PCR positive, तो with proper precautions के साथ आपको भेज देना उसको, like the protection जो होता है ना, level 3 protection जो होता है in the healthcare worker, वो करके और उसको करवा सकते हैं। It's not contraindicated in the neonate, आपको करवाना है।
Sir, are there any guidelines for COVID-19 vaccination in pediatric population?
Sorry, again question.
The COVID-19 vaccination in pediatric population, are there indications or guidelines?
तुम बात कर रही हो तो कोरोना वैक्सीन के हवाले से?
जी, कोरोना वैक्सीन।
कोरोना वैक्सीन की अभी तक कोई जो अभी स्पेसिफिकली देयर इज स्टडी इज गोइंग ऑन। एक वैक्सीन है जो कि लेस देन 16 इयर्स पे, दिस वैक्सीन जो कि अभी अवेलेबल है इन पाकिस्तान, दैट इज द सिनोफार्म, एंड दैट इज इंडिकेटेड आफ्टर द एज ऑफ 16 इयर्स अप टू द 60 इयर्स ऑफ एज। लेकिन द रिसेंटली डेटा फ्रॉम द यूएई, दे सेड के 60 इयर्स से ऊपर लगा सकते हैं सिनोफार्म को, तो वो उसके बाद लगाई जा रही है। But in the pediatric age group, Sinopharm is not indicated. Some other vaccine is available that is in process, was up to the age of 6 years. यानी 6 साल से 16 साल तक के बच्चों के, I don't remember the exact name of that vaccine, but वो 6 साल से 16 साल तक के बच्चों के लिए है।
Sir, I have a question. In a suspected case of COVID-19 in children, how often the PCR should be repeated? Like, what should be the frequency after every how many days we are to repeat the PCR?
You can repeat after 24 hours. You can repeat it after, if you are strongly suspect that this is the case of COVID-19 and the PCR is negative and you know कि PCR negative, false negative के कुछ chances positive हैं, तो आप पहले उसको rule out कर लें। अगर वो चीज नहीं होती है तो you can repeat it in 24 hours. लेकिन if you strongly suspect, then you can repeat in 24 hours.
Okay, sir. Thank you.
So there's this question in the chat box. Somebody is asking about Kawasaki versus COVID-19, and sir has already discussed that.
Kawasaki is very mimic to the COVID-19 presentation of MISC. MISC से बहुत ज़्यादा मिलती जुलती होती है Kawasaki, तो इसलिए हम Kawasaki को भी जहन में रखना होता है कि we are managing this child as a Kawasaki। अगर उसके सारे क्राइटेरिया पॉजिटिव आ रहे हैं Kawasaki के, तो फिर हम उसको जो है, देखो, the management of the Kawasaki and the MISC is both, two things are the same, the steroid and the immunoglobulin with the same dose, but if we can continue the aspirin in case of, if we are strongly suspect the Kawasaki, and if there is because of MISC, then we can add the tocilizumab.
So kindly tell about the role of a blood thinning agent like rivaroxaban in children. Is it recommended like it is commonly used in adults?
कौन सी? Rituximab, Actemra is used, yes.
No, sir. Rivaroxaban, any antiplatelet drugs for the blood thinning and anticoagulation drugs.
Which drug? Drug का नाम बताओ.
Sir, rivaroxaban. Sir, it is.
कोई स्टडी नहीं है. मैंने मेरी नजर से नहीं गुजरी. अगर होगी तो I don't know.
Okay, sir.
ये जो अभी ये गाइडलाइन बनाई गई है ना, these guideline is basically made by the UNICEF and WHO in the third world country. There is certain changes in these guidelines. अभी कुछ changes और आ रही हैं. Recently we inshallah ta'ala a day after tomorrow we have a meeting with the UNICEF people. There is the certain changes in the guideline. तो उसमें कुछ changes आएंगी. अगर आएंगी तो फिर मैं किरण से शेयर कर लूंगा तो वो आप लोग को भेज देंगी.
अच्छा सर, ये इंटरल्यूकिन 6 इनहिबिटर जो है वो हम बच्चों में दे सकते हैं?
क्या चीज बेटा? IL-6 inhibitor?
जी सर.
Yes. Actemra you can use.
सर इन मॉडरेट और सीवियर केसेस, मॉडरेट में कर सकते हैं?
मॉडरेट में नहीं, सीवियर केसेस में इंडिकेटेड है. CRS में जो होता है साइटोकाइन रिलीज जिसको आप सस्पेक्ट कर रहे होते हैं उसमें आप दे सकते हैं.
अच्छा सर.
इसमें पोस्ट टोसाई लैब्स वगैरह भी कुछ मॉनिटर की जाती हैं अडल्ट्स के अंदर. तो अगर आप टोसाई बच्चों में दे रहे हैं तो उसकी मॉनिटरिंग क्या होगी?
द सेम.
सर टोक्लुजुमैब इंजेक्शन अगर आप बच्चों में दे रहे हैं तो उसकी मॉनिटरिंग क्या होगी?
वही द सेम जो एडल्ट में हो रही है. नो चेंज ऑफ द मॉनिटरिंग.
ओके सर.
मॉनिटरिंग तो सेम है ना, वो तो आपको नहीं चेंज करनी है. ये आखिर तक रहा है ये. Okay, shall we continue or Kiran stop here?
So any more questions from anybody, or we can. Thank you, sir. Thanks a lot. It was a wonderful session, and thanks for taking out time. And we'll inshallah give you the feedback. And kindly everybody, please fill up the survey form. I have posted the link in the chat box. And see you in the next session. Allah Hafiz. Take care.